Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
Patrol with your host, Dr. Jeff Dikis.
And Dr. Leland Jaffe.
How you doing, Leland?
I'm good. It's good to be back. Been a busy week, been a good week. How's your week?
Doing well. Wife's out of town, so taking care of the kids and a dog and a cat that barely get along, and kids that barely get along sometimes. So a lot of video games, a lot of iPad time, but we're doing
what you got to do to survive, right?
Oh, exactly.
And I had that last week. My wife works for AbbVie, which is a pharmaceutical company, and they had an all hands on deck meeting in Chicago. So the company actually rented out an entire hotel, not a hotel floor, the entire hotel downtown Chicago. So she stayed downtown all week. I had the kids all by myself all week. So I know all about that zone defense parenting, if you will.
There's a new appreciation you have for everything the other person in your relationship does when they aren't there. It's like, wow, you do a lot of laundry. I had no idea. I can't figure out which kid belongs to which pair of pants. You know, they're 7 and 9 years old and the pair of pants says 7. Oh, but the tall one, he's older. He still fits into 7s, but not that pair of pants. That one is the younger one. It's like, I'm out. Yeah. I have no idea.
Yeah, I mean, I live with 3 ladies, my wife and 2 daughters, and they're all getting closer to the same size. So I'm completely out of my league when I try to put away laundry.
Yeah, for sure. So today I thought we'd do a deep dive into trauma, specifically ankle fractures. In my practice, I end up doing quite a bit of trauma. So I've done who knows how many ankle fractures over the years. And as you kind of get started, you think you fix it one way, and then you learn some tips and tricks and all the little ways to fix it over the years, and you kind of perfect the way that you like to do it. And at this point, I feel like I can kind of routinely take a glance at an x-ray, know what I'm going to do. And so we're going to kind of walk through that process here today. So what do you think about that?
Yeah, no, I think that's a great topic. And, trauma is definitely a challenging but rewarding discipline within our field. It's very rewarding to take something that's broken and fix it. And I think a lot of times we put so much pressure on ourselves when we're doing elective surgery in terms of pre-oping the patient, managing expectations, making sure that there's perfection afterwards. But sometimes it's nice when something comes in broken and you're just able to put it back together and fix it. I think there's a little bit less pressure in regards to perfection. I mean, even though we try to perfect our outcomes, but it's just a little bit different handling a non-elective versus an elective case.
Yeah, I agree. I'm a big fan of instant gratification. So going back to the, home life stuff, I'm not very good at vacuuming. And my rationale is, well, the floor's not dirty. I didn't spill a pot in a flower pot and it broke and there's dirt all over the floor. Because in that case, I'll vacuum it up. I'll see my lines. Look how clean it is. Right? It's a horrible argument because when you do vacuum, you still pick up a bunch of stuff you can't see. But I love instant gratification.
Yeah, it's been a interesting winter too. I think my instant gratification I appreciate is using the snowblower.
Oh yeah.
Again, I used to be a shoveler for years, and I grew up in Missouri. We had very few snowstorms that necessitated a snowblower. Living in Chicago now, usually the weather over the winter allows for a number of good sessions with the snowblower. But this year it's been pretty wild. I think there was one a good snowstorm that accumulated, and I believe it was when I was in Dallas for the residency interview, so I missed it. So I had to
Oh,
put my wife and 2 kids to work for that one.
well, that's what you pay them for, right?
That's right. That's right.
Otherwise, what are they doing?
That's
We
right.
live here for free. No, I'm just kidding. All right, so we're gonna jump into trauma, specifically ankle fractures here. So I want you to appreciate this first slide because it took me a lot of time with the nice layout and everything. So I don't
I
want
mean,
to
the
skip through
graphics
it.
are spot on.
Really soak that in for a minute because that took me a while.
For those of you on audio only, I would definitely encourage you to check out the YouTube link here because
Oh, that's worth
it
it.
looks fine-tuned.
Mm, top notch. All right. So first things we're going to talk about would be some classification systems. What are your thoughts on classification systems? How do you think people of different stages should best use them?
Yeah, good. It's a good question. I think we use a lot of classification systems. When I think back to when I was a student, I had and I don't want to date myself, but those of you that are in their 40s know of what a Palm Pilot is. So I had a Palm Pilot when I was a student externing, and you see
How
laughing on the
old
other
are
end.
you? Were you in an iron lung too?
No, but
Jeez.
I had all of my classification systems saved to my Palm Pilot, ready to be asked on externships, and I think I was incredibly underwhelmed on how many times I got asked about classifications. But my idea of classifications is if it helps me to figure out how to treat a patient, if it helps in that decision making process, I think it has and brings value. I always talk to the students and the residents I work with too. When you're using a classification system, it's really important to identify which one you're using. I mean, we can see here that there's quite a few that are listed just for one type of fracture pattern, in terms of Log Hansen versus Dennis Weber versus other class of AO classifications for ankle fractures. But really just important too, especially to identify which one you're using instead of staying like stage 3 fracture, right? Without really identifying what stage that classification belongs to.
Yeah, so I think it's important as a student and as a resident to know these. And I tell the students that rotate through with me that really it provides some amount of language that you can convey to another person quickly. If I say that they have an osteochondral defect, Burton Hardy type 4, well, if you understand the classification system and I understand the classification system, we're done. We both know exactly what that looks like and what we need to do about that. If you don't know the classification system, you're probably lost and thinking, I don't know what that means. Then we're going to have to dive a little deeper. So it does provide some simplicity to conversationally conveying information from one person to another. There's a difference in my mind between that and how we utilize the classifications. Do I look at a fracture and say, oh, that's a Log Hansen SER4 and think anything specific about, oh, I'm going to use a nail or a plate or screws? No, I'm going to look at the fracture. I'm going to identify it. I'm going to look and see what kind of components it has and be more specific than just knowing what classification it is. So there's a difference between understanding them and being able to use some of them to guide your treatment, which some of them can guide your treatment and some of them are just purely informational in my mind.
Yeah. And I think what you said was probably the most important thing is speaking the same language. And that's where it's important again to identify which classification system you're using. I read some notes and I work in a very interprofessional system where most of my charting goes into a hospital record. And so everyone that's reading my notes is not necessarily a podiatrist or a foot and ankle ortho or somebody that understands necessarily this language. So,
Sure.
really important to be clear that people that are not specialized in the lower extremity actually understand what you're trying to convey. But yeah, to your point, I mean, classification systems all vary. Some are purely just definition based in terms of defining different areas of an injury, and others can also help predict outcomes, can help predict complications, and can sometimes talk about different treatment reduction techniques, etc. So I think each of them brings a little bit of a different value.
Yeah, absolutely. So, as a student and a resident, obviously know them. You're going to get asked questions on them. It's going to be helpful to understand these and know them to speak the language per se. But as an attending, I don't necessarily stop and think exactly what classification system I need to utilize and classify it before I go in and fix the fracture. Some of them help guide that, but a lot of them don't, at least in my experience.
Yeah, and one other comment on that before we move on that I'd like to share is I'm always, certainly we treat the patient and not the X-ray, right? So we know that just looking at a static two-dimensional image is not necessarily all we need to know in terms of how to treat the patient. But I'm always more impressed when a student does a really nice job at analyzing an X-ray accurately, and as opposed to knowing the classification. Like if you can describe an X-ray and really describe it accurately, but you forget the classification system, I'm fine with that. That's to me a successful encounter, if you will. So I mean, they're important to know, and I think some programs will emphasize that information more than others. But just get skilled at reading an X-ray accurately, and I think that will definitely pay off.
I 100% agree with that. So when I ask students to read an X-ray, they'll throw out the classification and then I'll have to stop and think, yeah, I guess that's probably right. But really what I want to know is, you know, there's a distal fibular spiral fracture with increased medial clear space and a posterior mal fracture that involves less than 20% of the articular surface. Something like that that is going to guide our treatment much more than thinking, okay, what's the classification system for this? Again, I'm not saying
Exactly.
don't know them. I'm saying they may not come in as handy in the future as sometimes we put as much emphasis on them as a student.
Agreed.
All right, so this is a slide. If you're watching, you'll be able to see. If you're listening, you'll just have to envision. The point of this slide is that there's a huge variety of different injuries that can occur when we start talking trauma and ankle injuries. And that's obvious. That's true of any bone, that's true of any body part. But this just goes to show some of the subtleties of trauma and the differences that can occur that are seemingly, when you say ankle fracture, this is why you need to speak the language. Because if I say someone has an ankle fracture, all of these here are very different and treated very differently. In the top left is an osteochondral defect. We're going to treat that with arthroscopy, debridement. I use juvenile cartilage product with fibrin glue over top to seal the cartilaginous lesion. That's going to be very different than fixing a fracture. The second one in the middle top is an elderly person who has a bimalleolar fracture. It's very subtle, but you have to consider, am I going to treat this with surgery or am I not going to treat this with surgery? One thing that we fail to talk about, I think, as much is, like you said, we're treating the patient, not the x-ray. So when this person comes in, they're 82 years old and they are going to have a really hard time using crutches or even a knee scooter. And so in my mind, sometimes I will jump to more surgery in an older person, which may be a little counterintuitive because I'll let them walk on it a lot sooner. I'm going to put hardware in there and I'm going to let them walk on it a lot sooner because I feel confident that the bone's not going to displace because there's fixation within the bone.
Yeah.
So understanding the patient in addition to the x-ray is obviously very important. On the top right is a gunshot wound that may or may not require surgical intervention depending on when you get it, how you get it, the acuity of the nature of the injury. And then the bottom row are all different types of fracture that are all different from each other. There are things there that you need to appreciate: the level of the fibula fracture, the involvement of the medial malleolus. Is there increased medial clear space? Is there lateral translation of the talus? That's a common theme. Anytime the fibula breaks, the talus follows the fibula laterally, typically. And how are we going to bring that back into proper alignment? But all of these, the tenets of trauma are the same. When you get called from the ER, you need to look at the x-ray, you need to evaluate the x-ray, and you need to start formulating a plan of how you're going to fixate this fracture. You're going to prepare the patient for surgery. It depends on what level you're in, right? If you're a resident, if you're an attending. At my job, I don't admit anybody. I just how the ER calls me and says, "Hey, we got this fracture," and then I figure out, okay, do they need admitted or can they be splinted and follow up? But as a resident, you need to be able to understand how to work the patient up, figure out do they need to be admitted, and start thinking about your treatment plan.
Yeah, same with us. We'll get most of our patients referred to us from the ER after they've been reduced, splinted, and then evaluated for definitive treatment. Well, in terms of the tenets of trauma too, one thing that always resonated with me and this many years later is someone had told me, and I really don't remember who actually told me this, but they always said, look at trauma as a soft tissue injury with an underlying bone injury. And I think sometimes if we look at the x-rays alone, we kind of forget the soft tissue on top of it.
Yeah.
And I think that can lead you down some pathways that can get you into trouble. So just really appreciating the soft tissue. And when you look at these injuries, the elderly patient certainly can be treated differently than maybe a healthy, uh, you know, 30-year-old with an ankle fracture regarding their soft tissue envelope. So I think the approaches can be different for the same exact fracture pattern, perhaps.
Yes, exactly. That's one of the main takeaways from this is you might look at a fracture and think you're going to do one thing, but end up doing a completely different thing based on the patient. So, how to plan for trauma. So, obviously, we're going to use the tools that we have available to us. We're going to use X ray, CT, MRI sometimes, but that's more of an osteochondral defect or ligamentous tendinous injury rather than bony problem. So, frequently I use CT scans. The ER calls me all the time and shows me an X ray and something just doesn't feel right. Okay. So you're never, ever wrong to get a CT scan. They're relatively cheap, they're easy, and you do not want to miss something. I've picked up on injuries that did not seem likely based on the x ray. You might say, oh, that's a subtle, posterior malleolus fracture. Well, you get a CT scan. Oh, there's a huge dye punch fracture in the center of the tibial plafond. That's a much bigger injury and a lot more complicated than just a simple posterior mal fracture that looked non-displaced. So you're
Mhm.
never wrong to get a CT scan. I do have some students that say that they should get an MRI when they're in the ER. Just anyone that's listening, there's a huge difference between CT and MRI in terms of how long the test takes and what we're looking for. MRIs are typically much more expensive. They're not ordering MRIs in the ER for trauma, at least for what we do. I don't see that. Do you ever see them order an MRI for trauma?
Rarely.
Yeah, I don't know. I can't even think of a reason why you would do that. It'd be an outpatient thing. I'm not saying don't get an MRI. I'm saying you're not doing it in the ER. So X-ray or CT scan for further visualization of the trauma.
So
And
what
then
what
being
is
able
in your experience, what would you see on an x-ray that doesn't necessarily pass the proverbial sniff test? It just doesn't look right.
So commonly anything in the calcaneus, anything in an irregular joint. Sometimes I'll pick up some things in the ankle. Like I said, a posterior malfracture that's difficult to evaluate because you're looking at the lateral view and the central aspect of the tibia is obscured by the fibula. But most of what I'm picking up on are calcaneal injuries or talus injuries that look a
Okay.
little off. I'm looking at the cortical alignment of the posterior facet of the calcaneus, and I've had them miss, not them, just anybody miss calcaneal fractures because the way that sometimes the fracture happens is that there's a central sagittal split through the posterior facet of the calcaneus, and part of it is depressed, but part of it remains well aligned. So you can almost trick yourself and look at the line that's still aligned of the posterior facet and think that there's not a fracture. So part of it is just experience of looking at x-rays and saying, this doesn't seem quite right. Let me get a CT. But the
Sure.
other is mechanism of injury. If someone says he was walking down the hallway, well, I don't have a high inclination for a calcaneal fracture. If they say he fell off his roof, but we don't see anything, I'm getting a CT scan because that's weird. How do you fall off the roof and not
Sure.
have
Sure.
something going on?
What about peds
Well, what specifically? So,
in terms of
peds and
CTs?
yeah, I have no problem get a CT scan in peds, mostly because of the growth plates can trick you a little bit, and so there's a little bit of difficulty there evaluating, is that an irregularity? Is that their normal anatomic growth plate that just looks a little different than what we typically see? Is it trauma? So CT scans in kids I have no problem with. I think you don't want to miss specific injuries, especially in peds,
Yeah, I think the threshold for CT and peds would be a little bit lower in my experience as well.
for sure. So we're going to decide, are we going to fix a fracture? Or are we not going to fix it? And then you start thinking about as you advance through. So I always think of trauma or anything in our world in the eyes of different people, right? And so in the eyes of a student, they think one thing. In the eyes of a resident, you need to be able to bump it up to the next level. You need to know everything a student knows, but then you need to know a certain amount beyond that. And when you become an attending, it bumps up even higher. So as a student, you need to know, oh, that's broken. Okay, great. You can know the classification system, you can know all these things, but we're not expecting you to say, oh, I'm going to use a 4.0 cannulated screw in the medial malleolus, and we're going to use flexible fixation as opposed to syndesmotic screws, right? I'm not expecting you to understand that. But as a resident, you certainly need to start thinking about those things. And then as an attending, you need to figure out, okay, which company am I going to use? Okay, they have this plate. I really like that plate. Oh, but today I need to go posterior lateral with an anti-glide plate. I don't like their plate. I need to use this other plate. So it's kind of builds upon itself that you need to know all these levels as you get to an attending, know how to fix it, identify the fracture, and then figure out what your plan would be. And you need to do this relatively quickly. You don't have quite the luxury of time like when you're doing reconstructive surgery, because we're going to get to this trauma sooner than we would otherwise.
Yeah. A couple things I'll add to that is, ankle fractures are a very common case study for interviews, especially for residency interviews. And I think if you can start to add that specificity to your answers regarding screw sizes, types of plates, things like that, it really does show a higher level of, ability to interpret and approach these different types of injuries. So I think starting to know those, later in your schooling, especially into the second half of your fourth year, is important.
I agree.
Yeah.
I certainly find it impressive if they understand those things because those are advanced concepts, right?
Yeah. Yeah.
Cannulated
Absolutely.
versus solid screws and sizes of screws and headless compression versus, partially threaded,
Yeah.
fully threaded. They understand the idea kind of, but to be able to pick and choose which thing you're going to use, that's certainly advanced.
Yeah, and I think as an attending, it's important to be able to know how to do the same surgical procedure multiple different ways. Because I don't know about you, but sometimes we'll come to a case and our tray's not there, or for some odd reason, insurance didn't approve a certain tray, so we have to use a different tray, or
Yep.
something wasn't
Who's getting fired today?
exactly,
Who messed up
exactly.
sterility or who didn't bring the plate? I mean, who
Well,
didn't bring the
again,
trays?
and so those are things you have to be a little bit sometimes flexible to adapt to your situation. So
There was one time that we got into this situation. I think they'd brought the tray and it wasn't sterile, right? You open the tray and then you find a hole in the drape, and then you're like, okay, what are our
sure, sure.
options? And I think I ended up using a wrist plate on an ankle one time. You get a little bit creative. I looked at it, I was like, I think I could flip this and use that, bend it a little bit, and it was fine. But certainly not what I'd planned on doing.
Yeah. Yeah,
Get off
I
the
have a
grip
story to
sometimes.
share. I'm trying to think in my head, is it appropriate or not? But, I'll go ahead and share it anyway.
That's what the people want to hear.
So there's a few instances where, somebody was looking out for me. I don't know who, but, I remember this was when I was working in Missouri, and I came in the morning for a simple case, and I think I had done or had scheduled, 4 hammer toe fusions for a stroke patient that had contracted digits that were ulcerating on the distal parts of the toes, right? And so I asked for I was going to do just a screw fixation through the proximal additional interphalangeal joint, and the screw set that I had asked for was not sterilized, and it was going to be multiple hours. So by that time, I had to get to my office, and I couldn't do the surgery. So I canceled the surgery, and I was going to reschedule for a few days later. And I believe later that day or the next day, this patient passed away from another massive stroke,
Mm,
and terrible situation.
yeah,
But I'm like, wow, this could have happened on the
yeah,
OR table immediately post-operatively. I was like, "My goodness,
yeah. And then
unbelievable."
things like that happen. We're going down a different pathway here because we can certainly talk about that. Um, but then you beat yourself up, right? If you had done the
Right.
surgery, then you're trying to attribute that to something you did, right?
Exactly.
When whereas we realize things happen that are outside of our control and completely independent of anything we do. But if you had done the surgery, I guarantee you would have beaten yourself up thinking,
Oh
what
yeah,
did I do? What did I do wrong? Maybe I should have done this. Maybe I should have done that.
yeah, exactly. Um, anyway,
But
let's
I
get
think that's a good learning point. And I think that's good to share because, like I said, that's a different episode entirely. But it brings up a good thought process moving forward of patient selection. And sometimes you get to pick, and sometimes you don't. And sometimes you can select the best patient, or at least you think a fine patient, and have certain outcomes. So
yeah.
that's interesting to think about.
I mean, especially with trauma. I mean, trauma, we're very infrequently choosing our patients. We're on
Yeah,
call, the patient comes to the ER, you're dealing with it.
right. I didn't decide for the 55-year-old guy who smokes 2 packs a day to fall off the roof and break both of his calcaneus, right? That's a difficult case,
Yeah,
right? I don't pick that
absolutely. We had
patient.
a
They should come to
patient,
me.
yeah, we had a patient similarly that was, I believe, running from the police, jumped off a dumpster, fractured both heels, and then
Mm,
was incarcerated very shortly post-operatively. It's
yeah.
like, yeah, you're not choosing these patients.
No. You wish you could. You wish you could say, "Nope, no thank you."
Exactly.
And they say, "Nope, you were on call." All right.
Exactly.
I guess that's mine. Reducing the fracture. So, once you've identified the fracture with your imaging modalities, you're going to plan ahead for what you're going to do. You're actually in the OR and you're going to reduce the fracture. There are certain fractures that are quite easy to reduce. They'll just kind of whoop, pop back in. You're like, oh, that was easy. And there are some that are so difficult that you wonder, okay, what am I doing wrong here? There's got to be some sort of soft tissue impingement here. There's something, this does not seem right. Should not be this difficult. So, I think a lot of that just comes with experience. That's why we're in school for so long. That's why we're in residency for so long, to be able to see all the variety of different injuries and techniques that come along with the variety of patient and injury. And then subsequent to that, we're going to fixate that with our fixation of choice. The X-ray on the left there is a image of the post-operative of the elderly patient that we talked about previously. I used a fibular nail and a medial malleolus screw after reduction to hold those in proper alignment and allow them to walk on it sooner. I like the fibular nail in a more elderly patient because it's very minimally invasive. You don't disrupt their, a little bit more tenuous soft tissue structures, and you don't have a big incision to heal. And like I said, they can start walking on it. I let people with this injury, I'll let them walk on it pretty much right away.
Yeah. I think what you said that we should probably highlight again is the the counterintuitive way of thinking about whether to operate or not operate, right? It would be more risky to non-weight bear this patient for 6 to 8 weeks, in terms of their deconditioning or other complications that can ensue from non-weight bearing, falls, other
Yep.
risks. So operating certainly can be the less invasive way, if you will.
I
um,
agree with you. And I think that takes time to understand that.
Yeah. We had a couple patients that had pretty traditional Jones type fractures, but kind of reminds me of this kind of thought process. One of them was a patient who was about a week postpartum. And again,
Mm,
you're thinking a patient that just had a child you're not going to operate on. But again, are we really going to be able to non weight bear this patient for 6+ weeks with a Jones fracture, having a newborn at home? No,
right.
it's going to be a lot easier to just put a percutaneous screw in and get her walking right away in a cam walker. Another one was a patient that had a similar injury, and she um, did some type of house cleaning business and had to walk, had to work, had to put food on the table. And again, being on crutches and non weight bearing for 2 months was not an option. So again, we just put a stainless steel screw across it, put her in a cam boot, and walk right away. So again, I think that decision making process does take some time, but it can be a little bit counterintuitive to what you might be thinking.
Yeah, I think that's a hugely important point. Um, so to spin it into a different realm, there are some difficulties that come. Sometimes I'll see someone with a bunion deformity, and you look at the X-ray, and you're like, "Oh, that's a classic head procedure, a classic base procedure." And you start talking to the patient, and they say, "Well, I don't have any paid time off work. I don't have any sick time. I need this to go away, and I need it to be as soon as possible."
Right.
Well, now all of a sudden I'm talking to them about a silver, right? A silver bunionectomy. I'm just going to shave the bone down. And the students will say, I thought we didn't do those anymore. I said, well, wait until you're out in practice and you get a patient telling you that they can't take time off of work. Their foot hurts, they got this giant bump, but they have no time to recover. I can't do a lapidus. I can't, in good conscience do a head procedure and let them, fall to pieces, right? And so the patient guiding treatment is what my point is here of taking away from that. We get so narrow-minded looking at x-rays, but the patient will help guide your treatment option as well.
Yeah, agreed.
So this is the one we already talked about on the left with a subtle bimal fixed with intermedullary nailing, a gunshot wound with severe comminution, no fibular shortening. If there was fibular shortening, I'd plate this, bring it out to length. But without fibular shortening, treat it non-operatively. Speaking of incarcerated, this patient was incarcerated. They stole a car, tried to run over a police officer with the car. The police officer fired and sustained this injury. So this is not a patient that I wanted to sign up for as being one of my surgical candidates. So they got a cast and it healed. He did fine. So the difference between pediatrics and adult, he had asked about that previously. So the
Sure.
main difference between these two injuries, which you look at the x-rays here, if you're watching, are very similar. You look at the preoperative of the x-ray on the left and the preoperative of the x-ray on the right. They both have, Weber B oblique fractures, medial mal components with lateral translation of the talus following the fibula, and significant injuries. What are your thoughts on these x-rays here?
Yeah. So looking at, I mean, they look similarly in regards to the fracture patterns. I mean, I don't think you could find two that look the same, but yeah, absolutely.
Right.
With the open growth plates, it certainly changes the approach to how you're going to stabilize the fracture, what you can put across the growth plate. It looks like the one on the left, though, if we look at the pediatric fracture, there's starting to get closure of the growth plate, if I'm not mistaken, correct?
Yes, that is correct. So I
Yeah,
think he was like 16 or 17. If you look very closely right here, which is the open fibular growth plate. So again,
right.
just making sure that I don't have any fixation across the growth plate. And if I do have to fixate across the growth plate, I'm using smooth K-wire fixation. I'm going to have
Yeah,
to go in and take out all this metal anyways. So that's why I put a plate on the distal fibula and kind of bridged across the open growth plate of the fibula, knowing that I'm going to take all this hardware out at some point anyways.
right. And again, kind of going back to the point we made originally, we could have a student look at this and say, it looks like there's a Salter Harris 2 fracture of the fibula or a Salter Harris 3 of the tibia, and really not understand the fracture pattern,
Yeah.
the fixation options based on the fracture pattern, right? So being able to go through and analyze the X-ray accurately is going to be more important than coming up with a classification system most of the time.
Right. And just for completeness sake, here on the right, we have an adult who underwent the very similar fixation, but I did not care about any growth plate at the distal fibula. So you can see here on the pediatric where the screw is missing across the growth plate, whereas in the adult, I don't have to worry about that. And then more formal and permanent fixation in the medial malleolus than compared to the pediatric patient.
Yeah. So Jeff, you mentioned earlier getting the fibula out to length. What radiographic measurement do you like to look at? Shenton's line? Do you measure that talocrural angle, or what kind of radiographic assessment are you using to analyze fibular length?
I don't know if I should admit this or not. So I just do it. I just put it
Okay,
where it should be, right?
got
To
it,
me, I
got it.
can understand, you can look at dime sign, you can look at all these
Right,
things,
exactly.
but I can just look at an x-ray and just say, does this look correct or not? I'm not saying that's the way you should do it. I'm just saying I know I can look at something and say, oh, that's too short, or
Right.
no, I need to bring that out a little bit more. So I'm not looking at a one radiographic parameter. I've done enough of these that I just number one, with your reduction, right? It depends on the fracture. If there's comminution, it makes it much more complicated because you can't get perfect alignment of the
Right.
fracture ends. And so you have to guess a little bit more. Those are the ones that people tend to leave short. At least that's what I typically see. If it's just a simple fracture, then you can realign the fracture. And as long as it goes back into perfect alignment, you know that's where it's supposed to be because it's fitting back together like a puzzle piece. And so,
Right.
most of the time, with a simple transverse or oblique fracture, I'm going to put my reduction clamp on there. I'm going to spin it. I'm going to pull it out to length. I'm going to clamp it. I can visually look at it clinically in the OR, put my finger on it. Yep, that's perfect reduction. Take an x ray. Yep, that looks perfect.
Yep.
So most of the time, I don't care about that because I already know that I've got optimal reduction. It's the
Sure.
ones that are comminuted that are much more complicated. So this is a slide that's purposefully busy to kind of show all the different varieties of hardware and screws and plates and all the latest and greatest gadgets and gizmos that someone's going to come into your office and buy you lunch and tell you how great their stuff is compared to the other one. And maybe it is, and maybe it isn't. But the takeaway here is that it's never wrong to know your options. It's never wrong to understand all of the options available. I've tried everything on this slide. At one point or the other, I've tried everything on this slide. And once you do that, then you'll be able to figure out what you like and what you don't like, and what works well, and maybe what doesn't work so well in the real world compared to a sawbones. But understanding the variety of hardware and soft tissue options that are out there, I think only benefits you and potentially benefits your patient. Do you get bombarded with things in the industry world?
Yeah, not a tremendous amount. I don't know, being in academia, if I'm not approached as frequently. I mean, we do have the option, and industries are really generous with helping us put on workshops with our students. Regarding the fixation, in my experience, I don't have a lot of options because our hospitals are contracted with certain companies, and that's our option.
Yeah.
It's not, pick whichever company you like at the last seminar, and bring it into the OR. For me, it's a little bit more limited to what is contracted with the hospital that we work with, and that's what we're able to use. Fortunately, most of these companies do carry similar lines of plate fixation, rigid, non-rigid, syndesmotic fixation.
Yeah.
So there's a lot of options available.
So just to let people know what that means, when someone is contracted with the hospital, at least in my specific case, they are contracted with two specific companies. And if we use 90% of our cases are utilizing those companies, then they get a significant discount on their pricing structure. It means they have a contract, they have a deal. Hey, if you
Right.
use this amount, then we're going to give you a lot of, we're going to give you a big discount, which could be millions and millions of dollars, depending on the size of the hospital system, the number of surgeons, and the number of cases. The difficult time comes when you want to try to prove to them why a different product is substantially different enough that you should be allowed to use it. Because there's a lot of technicalities here when you're comparing product A versus product B, and they look similar in theory, but you're trying to explain them the practicality of using this other product. It becomes very difficult. And you also think, oh, well, then why can't company C come in and match the pricing? Well, yeah, that's all well and good, but then that throws off your 90% ratio. And if you do that all the time, all of a sudden you're out of your 90% and they're not getting the discount. So there's a lot of complication. In a perfect world, you could just pick whatever you want, use it. They all cost the same. They all do the same thing, and we just move on. But that's unfortunately not the real world.
Not at all. In fact, I've done. I remember a particular case I did. It had nothing to do with ankle fractures, but it triggered a phone call from the CFO of the hospital. Why there was a bill for X amount of dollars. It was actually a 3D printed navicular bone,
Yeah.
um, that called me into the office. I felt like I was getting called to the principal's office.
Yeah. Yeah. I'm always amazed how some people are able to get away with anything they want, and then some people can't. So I
Yeah.
think it really depends on surgeon volume, right? Are you doing enough other cases to offset some of those costs of that one particularly expensive case? But
Right.
yeah, I agree with you. Sometimes you do something and you get a phone call and you think, uh oh, what did I do now?
Exactly.
So, one thing that you may have noticed if you were watching along is that not one of those ankle fractures that I fixed had a lag screw in there. I do not put a lag screw into any fibula fracture that I fixate. The reason is, well, two reasons. Number one, I'm lazy, right? It's much easier to not do a lag screw. Lag screw might be the hardest part of the entire case. You make a lateral incision to the fibula, the fracture is oriented obliquely, and you're trying to get your wire or your drill to go perpendicular to the fracture. The soft tissue is fighting against you. You want to go back here, oh, but the perineals are back there, and you can't get a good alignment. And I end up saying, all right, screw it. I don't want to put a lag screw in. And so I haven't done a lag screw been out in practice now 9 years. I haven't done a lag screw in 9 years, and they've all healed. Or let's say if they didn't heal, it had nothing to do with the lag screw.
Yeah.
And so this is an article that kind of backs up my stance, I suppose, looking at the necessity for interfragmentary lag screws with pre-contoured lateral locking plate. This was specifically an SER, lateral malleolus fractures, but I don't use a lag screw in any type of my distal fibula fractures. So I'm not sure if this is controversial or not. I've posted some things online and gotten some pushback from some people, but I think it's kind of the old school way of doing things to put a lag screw across this. I find that I'll just put a fibular plate on. In this case, it's a more of a straight plate because of the higher proximal fibula fracture, but sometimes an anatomic distal fibular locking plate, and the fractures heal.
Yeah.
So, what are your thoughts on that?
Yeah. So I attempt to put an interfrag screw I should say. I do
Mhm.
agree. Sometimes that angle can be a little bit challenging, especially with soft tissue constraints. And if there's a struggle, I'll just bypass it and put a neutralization plate once we have the fibula out to length or reduced. So I think the outcomes once you have stability, osseous stability with your neutralization plate, it's going to heal.
Yeah, I should tag on all my hundreds of ankle fractures that heal just fine with this study and post a
That sounds
big.
like a good retrospective analysis to look at here.
What that sounds like is a lot of work that I don't have time for.
You
They're
got
always
students with you?
Yeah, 1 month at a time. They're, like, here and gone, so, yeah, that's, I mean, we do some research, but, uh, yeah, I'm always impressed by the people that have time to do research because, that is just such a daunting, uh, ordeal sometimes, so,
Yeah. I mean, I think
anyways, people listening.
10 years ago, it'd probably be, taboo to not put an interfrag screw in and accept the outcome. I think in 2024, there's enough data to support whether, not putting an interfrag screw on and still expecting a good outcome.
Yeah. So anyone listening, tag on my hundreds of cases and know that all of my fractures heal without a lag screw as well. So something to think about because it can be a little tricky. So if you realize, hey, evidence backs it up, research shows you don't need a lag screw. Why are we wasting all this time? It's a little bit of extra money, but it's still time and money. Time in the OR costs money. One
Right.
screw, who knows what that costs, but save some time, move on, don't need it.
Again, if you got good reduction of the medial gutter, the fibular length, the mortise looks congruous, you're good to go.
Yeah, I agree. All right. So that kind of wraps up trauma. Anything you want to add to ankle fracture trauma? We kind of dove into the classifications and all the little
No, but
tips and tricks there.
ironically, as we're talking, I literally just got paged from the ER, so
Nice.
live on the podcast. So hopefully nothing too urgent.
Do you need to get that?
Yeah, probably. Give me a second. All right. Sorry about that. Mhm. Okay.
Did you save a life? All right. Let's jump back into the podcast here and spin the wheel of destiny. What do you think, Leland? Are you feeling lucky today?
I don't know. Let's give it a go. That's not a that's not a vote of confidence there.
At least you're honest.
Yeah, let's do it.
All right. Spin the wheel of destiny. What do we
I
got
thought it was
today?
gonna land on the lag screw there for a second. Oh,
All
it's like
right.
watching Pat Sajak spin the wheel and hope that he lands on the $5,000 before the final round. You know,
Watch Wheel of
not that I'm
Fortune?
watching a lot of Wheel of Fortune. I promise.
I watch it if it's on. It's more
I mean,
difficult than you think, especially if you're up there.
but it's Hangman, right? It's crazy that that's been on for decades.
It is. There's certain shows that people love, and as long as they're making money, people are going to keep watching them.
I mean, they play Hangman. It's unbelievable.
Yeah. All right. So today we're going to be debating syndesmotic screws versus flexible syndesmotic fixation. So last time you get to pick. So I'm going to defend my tried and true go-to procedure,
Yeah,
which
dude,
is
do the honors.
flexible syndesmotic fixation. So
Oof.
you're going to be stuck with syndesmotic screws. So
Okay.
um, I think you started last time. I'm going to start
Yeah,
this time.
yeah. Take the reins.
All right. So when we have a trauma and we identify that there's an ankle fracture and we identify that there's a potential to the syndesmotic instability or syndesmotic disruption. So specifically for the younger people, the ligament connecting the tibia to the fibula just above the ankle. Certain fractures will be pretty classic to have syndesmotic disruption, which means that ligament is torn, either all or part of it. There are multiple parts to the syndesmosis. And if that piece of ligament is torn, you're going to get diastasis or separation of the tibia and fibula. There's two ways we can put that back together. One is with a screw, and one is with flexible syndesmotic fixation. I'm being careful not to say any trade names. There's a lot of them out there, but I'm being careful not to say that. So, flexible syndesmotic button or fixation. And in my mind, this allows two things. Number one, it reduces the tibia and fibula, specifically the syndesmosis, in the transverse or frontal plane or whatever you want to call it, side to side. You're bringing these two pieces back together and you're holding it there so that they cannot separate. But it also does another thing, which it allows the normal movement of the distal tibia and the fibula. When we ambulate, there's a little bit of motion between the tibia and the fibula as the talus moves through its ankle joint range of motion. There's a little bit of widening and a little bit of up down motion that happens at the syndesmosis. So a flexible fixation allows them to retain this normal motion and potentially maintain some normal function of this ligament while yet repairing it. What are your thoughts?
Okay. So I can buy into a lot of what you said. Maybe all of it. We'll see. Uh, but when I was taught ankle fixation, and I had to check my Palm Pilot while you were talking to reference my source.
Still have it.
I
You
still
still
have it.
have it.
That's right.
It's an
Um,
artifact. It
no,
might be
but
worth something.
I was of the initial training where when we have syndesmotic instability and we do screw fixation, where you do 3/4 C's, 4/4 C's, just for a traditional non-diabetic ankle fracture. Um, we were routinely taking these out 6 to 8 weeks later, maybe 10 to 12 weeks, depending on what your preference is, which is an elevated cost of care. It's another trip to the OR. It's a second small incision, albeit there is risk anytime you make any incision. And the screw came out. I think if you fast forward to 2024, there's enough evidence to suggest you don't necessarily need to take out syndesmotic screw fixation, and I think we can leave those in safely. Even if they break, I think there's enough evidence to support that they're not necessarily going to be symptomatic. And so that second surgery might not be necessary. And we can just go ahead with our more traditional screw fixation, knowing that we don't necessarily need to go back for a second surgery, which was probably one of the initial motivations to introduce other options into play regarding the flexible fixation. The
So
other
if we
option too is, especially when you're dealing with diabetic patients, which is a lot of my population, we're typically doing two and or three syndesmotic screws just to twice the fixation, twice the non-weight bearing period with a diabetic ankle fracture compared to, or neuropathic ankle fracture compared to a more traditional one. So
Agreed.
gives us a little bit more ability to put some robust fixation in.
Yeah, I think that's reasonable. Going back to what you said before, though, I know classically we were taking out these syndesmotic screws because it does limit some of that normal articulation and motion, right? Which is why they do break. That is proof that there's normal motion at that tib fib articulation because it moves enough that it gives way and it breaks. And so when you compare the increased cost of flexible fixation compared to stable screws, obviously the flexible fixation is more expensive.
Right.
And classically, in my mind, it makes more sense to put that in. You're not having to take it out. There's not a second surgery, like you said. Now, if you decide to leave it in, that's not unreasonable, especially in a certain subsect of population, maybe an obese patient, a neuropathic patient. They tend to do better with more stability and rigidity than flexibility. A younger person, an athlete or something, they're going to need much more flexibility, much more range of motion. They're doing maximum dorsiflexion, maximum plantar flexion. The talus is moving through the uh, mortise with the wider part of the talus. When the wider part of the talus moves into the mortise, it's going to cause tib fib separation. If you have a syndesmotic screw, they're not going to like that at all. It's going to cause a lot of stiffness, limited dorsiflexion, limited mobility. So it depends on the
Sure.
age of the patient, but a younger patient is really going to be limited when you put a syndesmotic screw in there. The other component is I don't want any broken hardware in my body. Do you want a broken screw hanging out your ankle?
Eh.
All right. Well, you're different than I am because I don't want just a big broken chunk of metal hanging in my ankle. And I think if you asked any surgeon who said, "Oh, it'll be fine, it'll break," they'd probably say, "Well, it's fine for them. I don't want a broken piece of metal in my ankle."
Sure,
Um,
fair enough.
because you're assuming that it's breaking at the exact correct spot, which is halfway between the tib and the fib. And sometimes it breaks right at the fibula, right at the tibial cortex, somewhere in between. And then they have this piece that's kind of sticking out, and maybe then you go in and take out the fibular portion of it, but they still have this piece of metal that you'll never be able to get out stuck in the tibia.
No.
And, let's say we're converting to a fusion or an ankle replacement or something. You've got this broken screw stuck in there. That's a nightmare. How are you going to get that out of there? Well, you're probably not. You're going to be working around it. Might be drilling through it or around it, but it's going to be difficult. So,
Yeah.
um,
What about prominent knots? If you're when you're tying your fiber wire or whatever suture you're using, knot irritation from flexible fixation.
so I have to be careful here. There are certain types of flexible syndesmotic fixation that have knots, and some of them don't have knots. Some of
Okay.
them are a slip knot or a slip stitch that's going through and cinching down, but it's not a knot that's prominent. So I don't typically see that in the
Okay.
fixation device that I use of knots being prominent. Now,
Sure.
there is one thing. I'm going to give you a bullet point here. I'm feeling generous today.
Okay. Sounds
So
good.
I'm gonna hand one over to you. I'm gonna give you a talking point. I have seen some people have some irritation. Irritation is not the right word. Sensitivity. I hesitate to use the word allergy because it's not really an allergy, but they don't tolerate the flexible suture, I guess, without trying to use trade names. The flexible piece of suture that's connecting the two metal pieces together, they don't tolerate that. Their body creates a reaction to that, and they have difficult wound healing right at that specific spot in the fibular incision. I've seen this.
Hmm.
The proximal part of the incision is healed, the distal part of the incision is healed right at that flexible syndesmotic fixation. I'm tired of saying that.
Yeah.
So much
Exactly.
easier to say the trade name. The flexible syndesmotic fixation, I've seen them get little spitting. The wound doesn't heal. They've got some sinus drainage, and
Yeah.
I'll have to go in and take it out. I have seen that. So there's a bullet point for you.
Okay. Appreciate that. Good.
You're
Thank you for the
welcome.
charity.
Yeah. So, I mean, I think that, as we joke around here, Typically, I don't know that many people in a younger patient would skew towards the syndesmotic screws. And I don't think that typically people who fixate fractures would put a flexible fixation into an obese patient or a neuropathic ankle fracture. I think we've shown
Exactly.
that those there is an indication here. We can argue back and forth. We should do this. We should do that. But I think in this case, we can probably agree to disagree that there are indications for both of these products
I
or
agree. I think,
techniques.
yeah, and that's where again we have the same fracture pattern, but we've got a different soft tissue and body surrounding that bone, and I think that really helps to dictate what's best for that particular patient.
Yeah.
Yeah,
So I think there is quite a variety in the different types of flexible fixation options. Not as much variety in the type of syndesmotic screw, other than I have seen people use cannulated screws for syndesmotic fixation. What are your thoughts on that?
yeah. Not a. I would not select that. I think for me, not in terms of. I think it's important to not. It's a positional screw. It's not a compression screw, right? So we're not doing your over drill, under drill. We're not using a partially threaded screw, right? It's a fully threaded screw. I think there's probably more debate in terms of 3/4 C's, 4/4 C's doesn't matter, as opposed to using a cannulated versus non-cannulated. But I'm going to be putting in a non-cannulated screw.
Yep, I agree with that. I would not use a cannulated screw. It might seem a little easier to throw your wire and verify your optimal alignment. So here's what I would do. Anybody listening, tips, tricks, whatever. If you're going to throw in a syndesmotic screw and you don't want to just commit to the drill right away, use a cannulated technique, but throw a solid screw. And we do this frequently in another body part. It's called a Jones fracture. Every time you do a Jones fracture, we're doing a cannulated technique solid screw. I've seen
Right.
people put in cannulated screws for Jones fractures. I don't agree with that either. Petites their own. But we're
I don't
doing
like
a
that.
we're doing a cannulated technique, which means you throw the wire, in this case, the syndesmosis, in the Jones fracture down the medullary canal. You're verifying on multiple views of both of those things to make sure that you're in optimal alignment. You're going to drill with the cannulated drill bit. For those who don't know, it means it has a hole in the middle of the drill bit that slides over top of the wire. And as you drill, it's following the wire exactly. You want to make sure that your hand is perfectly aligned with that wire. Otherwise, you will shear the wire. If your hand is off and you drill, the drill is powerful enough to shear the wire off. You know how I know this? I've seen me do it. It can happen. So you need to be perfect when you drill across the wire, that you are sliding that drill over top of the wire first to make sure you're in proper alignment, because it's easy. I see students do it all the time. They want to lean their head over and look and see what they're doing. But in doing so, they're raising or lowering their hand and they're going to shear that wire. So that's just a little tip.
Yep.
So I
Excellent.
think not putting a cannulated screw in for both those things would be the correct answer, because you want the structural rigidity. If you're trying to get this to break, I guess maybe you could do that,
No,
but I don't think you want it to break. I think you want to provide that structural support, at least initially in the first 3, 4, 5, 6 months of
exactly.
fracture fixation.
Yeah, and that's where I think a solid body screw is going to be able to provide that for you more consistently.
Yeah, for sure. So any other
Yeah.
thoughts on syndesmotic fixation versus flexible
No, I think we
fixation
hammered that home,
options?
went home pretty well. I think indications for both. I think just knowing the patient and knowing what your goals are, and treating the patient, not the X-ray, is going to be important in terms of preoperative planning.
Yeah.
I think if
So
you
if
do use
you
a solid screw, though, it's good to have that conversation before surgery regarding what the plan is afterwards. Are you going to take it out? Do you not need to take it out? We might need to take it out if your ankle's stiff and we're looking for more motion. If it breaks, we might take part of it out, and that's okay. I think having these conversations ahead of time so that the patient isn't caught off guard why they have a broken screw still in their ankle.
Sure.
But if you have that documented ahead of time and they're aware of that, I think that's really important so you don't get yourself into trouble.
One other point, just to make sure that I win the argument here and that there's no confusion about who wins this argument. Um, let's talk for a minute about malreduction of the syndesmosis. And so certain studies have shown that malreduction of the syndesmosis is possible. overcompression of the syndesmosis is possible. There are two ways that you can overcompress the syndesmosis in my mind. One is using a screw. Certain screws have better bite. Certain screws are going inadvertently, you're going to get some compression across that. Some people are maybe doing it incorrectly and over drilling. I don't know. But you can get some overcompression of the syndesmosis with a screw. And the other way that you can get overcompression of the syndesmosis is if you take a clamp and you clamp down the syndesmosis. I used to clamp down the syndesmosis. I think that was what we kind of used to do. We take this big old reduction clamp, you put one on one of the open holes of the fibula and on the medial mal, and you clamp it down, you cinch it down, and then you put your flexible fixation across it. Well, that flexible fixation is going to lock that into place. If you've overcompressed the syndesmosis, then all that flexible fixation is doing is holding that in wherever you left it. So if you compress too hard with the clamp, it's going to hold it there. Anymore, I don't use a clamp at all. I throw the wire, I do the drill, I put the device in, and I cinch it down by hand with the foot at 90 degrees in rectus alignment, which is the wider part of the talus. So you're making sure that you're not compressing. If the foot is plantar flex when you lock that in, and then the talus moves with the wider part anteriorly into the mortise, they're going to get a lot of stiffness. So I make sure I do it with the foot at 90 degrees, which is the wider part of the talus, to not overcompress.
Sure. Yeah. So, I mean, if you're having difficulty getting reduction of your syndesmosis, then more than likely there's probably something going on in the medial gutter or a deltoid issue that's preventing that reduction, as opposed to just how tightly can you clamp down on the bone.
100% agree. And we should have an entire episode about medial malleolus and increased medial clear space and interpositional periosteum that flaps into the medial gutter. I guess we could talk about that real quickly right now because I didn't touch on it earlier. I used to not open the medial malleolus. I used to only fixate medial malleolus fractures percutaneously. We know that because of Vasal's principle that when you fix the fibula due to ligamentous connections, that typically the remainder of the fractures are going to fall into alignment. This is typically how we fixate or how we get posterior malleolus fractures into proper alignment. But a lot of times you fixate the fibula, it pushes the talus medially back into alignment, which then reduces the medial malleolus. And it's so tempting to look at that on x-ray and say, it's perfect. Why would I open that? Let me throw these two percutaneous screws across it. I had an orthopedic attending one time tell me, don't do that. Always open this medially. And you're thinking, what's he talking about? I think I'll put my percutaneous screws across it. It'll be fine. If you don't open it, there is a much higher chance for non-union because when the medial malleolus fractures, there's a thick layer of periosteum. That periosteum comes down over the medial malleolus and it eventually turns into the thick deltoid ligament medially. When you fracture along the medial malleolus, that periosteum tears and it folds into the fracture. And so even though your fracture looks good, it probably has a piece of periosteum that's folded into the fracture site and will lead to non-union. Even if you fixate it perfectly, even if your reduction looks perfect, you will get a non-union of the medial malleolus. You'll be scratching your head thinking, what's going on? It looks perfect. Yeah, what did I do? So I always at least make a very small incision over the medial malleolus, clean out any interposing tissue, then reduce it. Then you can still go down underneath that incision and throw your wires percutaneously. But I always open up the medial malleolus.
Yeah, and I think that's a great pearl. And that there's very little soft tissue or neurovascular structures there that you need to be worried about. It's not much more dissection, and if it's going to save you long term, that's an excellent pearl.
Yeah, you can find the saphenous vein in a hurry though, so don't skew too far anteriorly. You're going to find the saphenous vein and wish that you hadn't.
Yeah, well, if you don't see it, don't go looking for it. It's not there.
No, don't go looking for it. All right. Let's go into case presentation real quick. So this is a case that I had previously posted to social media for anyone that follows. My handle is FootDocDuo. I post some educational things on there. So you can follow along that way, or you can watch us on YouTube as we go through this case. But this was one thing. A lot of people know how to fixate ankle fractures. A lot of people know the stuff that we've talked about, especially the older people. So for us to appeal to kind of a broader range, I thought it would be interesting to present on something that I've done a few times that I've never seen anyone else talk about. which is an ACL guide for an ankle fracture, which on the surface sounds ridiculous. You're like, an ACL guide? What are you talking about? I don't even know what an ACL guide is. What are we doing? Well, there are very unique. Oh, sorry. Go ahead.
No, I was just saying it makes a lot of sense. You know, when you talk about different types of hardware, I think the one that a lot of us get side-eyed is when we ask for a speculum for gastroc recessions.
Yeah.
So if you
What are
ask
you
for
doing,
the
doc?
old, like, speculum for an orthopedic case, that's where you get some good side eye from the staff in the OR.
That's a pretty good one. So in this case, this is a case of a 19-year-old female involved in an MVA, came in with an ankle fracture. So it looks to be a rather simple transverse medial malleolus fracture. This is a case that I got a CT scan on, because this is one where you're thinking an isolated medial malleolus fracture. That seems unusual to me. I see enough fractures that there's usually something else going on. Well, anyways, I got a CT scan, no other injuries. So I was proven wrong. That was the first time I've ever been wrong, by the way.
That's right.
So in this ankle fracture, there's no fibula fracture. There is a transverse medial malleolus fracture and syndesmosis. Typically, with this type of injury, we think about syndesmotic injuries with rotational injuries. Well, everything kind of goes out the window in a car accident because you don't know what happened. Was there impaction? Was it lateral impaction? Were they driving and their foot was on the brake pedal and they had axial loading up the bottom of the foot? Was there a rotational component of what happened in the car? You don't really know what happened. So you kind of need to keep an open mind, I think, about this case. So we go ahead and we fixate the medial malleolus. You can see here that I opened it, got what I think is perfect reduction of the cortical line of the medial malleolus. And just looking at the medial clear space, it's questionable. This is one of those cases where you kind of look at it and you think, that looks a little wider than I would expect. I've got the foot dorsiflex, so the wider part is into the mortise, so you're not getting tricked with the foot and plantar flexion, which is going to obviously make the narrower part of the talus. So, I've done this enough. I'm not falling for that trick. But you look at that medial clear space and you think, what's going on here? So then you think, well, maybe there's a deltoid component. So for me, there's two possible ways that we can reduce the medial clear space. One is open it up and do a primary deltoid repair. I don't typically do that. Is it wrong? No. But for this, if you fixate the syndesmosis and you tighten down the tib-fib articulation by nature, you're going to get decrease of the medial clear space. You're going to reduce the medial clear space. So I stressed it. And it wasn't an obvious syndesmotic injury. But in my mind, I would much rather fixate a syndesmosis that doesn't need it than to miss a syndesmosis that did need it. If you neglect a syndesmosis, it's an absolute nightmare. I've seen it. They come in, they start to develop this synostosis between the fibula and the tibia at the syndesmosis because of the diastasis and the instability of that joint. They're getting friction and rubbing, and they develop this synostosis. It's very painful at the syndesmosis area, and it's very difficult to treat. So in my mind, it's much better to go ahead and fixate the syndesmosis than to not fixate it. There's an episode from The Office where Dwight is trying to catch someone, and he says,
"Better 1,000 innocent men are locked up than one guilty man roam free."
And that's how I feel about syndesmosis. I would much rather fixate 100 of them that didn't need it than to miss one of them. I'm joking, of course, but I will skew towards fixing the syndesmosis if it's at all questionable. So in this case, I was fixing the fracture medially, and typically you're fixating it laterally. So when you throw from lateral to medial, you're going from small bone into big. It's easy to hit the big target, which is the tibia, starting from the fibula, but it's hard to hit the small target, which is the fibula, starting from the tibia. So I've used an ACL guide. So for those who don't know, an ACL guide is a positioning device where there's a cannula that a wire goes down, and on the opposite side of the ACL device is a tip. And when you put it's like a targeting device. It's not too dissimilar from jigs, when we do TTC nails or something. But anyways, when you throw the wire through the cannula, it's going to hit the tip of the positioning device on the opposite side. If you're looking online, you can see what I'm talking about clear as day. If you're listening only, I'm trying to describe it so that you can picture it. The wire goes down the cannula and then hits the fixation or the tip of the other arm of the targeting device. And so I've used this to throw a tightrope wire from medial to lateral to ensure that I'm in the central aspect of the fibula. So talking previously about malreduction, if I were to miss the fibula either posteriorly or anteriorly, I am potentially going to at least be trying to malreduce the fibula in the incisura of the lateral tibia. And I don't want to do that. I want to make sure that the flexible fixation device is oriented exactly where it needs to be in the center of the fibula into the tibia, if that makes sense.
I think it's an excellent pearl. And I think you're exactly right. I think a lot of us have a good appreciation of how to hold our hand, angulating about 30 degrees anterior to hit the tibia through the fibula. Right. But when you're going the opposite direction, it can be a little bit more nuanced.
Yeah. So naysayers would say one thing: why don't you just make a small incision over the fibula, start your wire in the fibula, go into the tibia like you typically would? And you could. That's not wrong. But with this device, I don't have to make an additional incision. I can just throw it from medial to lateral and know that I'm central in the fibula. So if you're watching online here, I get a true lateral to see the wire is in the central aspect of the fibula, which is not surprising because that's exactly where I threw the wire through the targeting device to exit through the central aspect of the fibula. I throw the fixation device and it's in good alignment. So is this kind of a niche thing? Yes, of course. Is it rare? Yes, but it's just like a little tip or trick or something. If you're having some difficulty, go ahead and grab an ACL guide and utilize it in this case. There's a second type of case where I'll use the ACL guide to throw a flexible fixation device. And that would be in a fracture where I'm using a medial plate and a lateral plate. So we know that if you have a vertical medial shear fracture of the medial distal tibia, medial malleolus, but even a little more vertically oriented, you may tend to use a plate. In this case, I'm using a hook plate to stabilize a vertical shear fracture of the medial malleolus. But that plate on the medial tibia tends to be a little bit wider, and there's not a whole lot of real estate in the medial aspect of the tibia to get your flexible fixation device to sit. And if you do have room, you need to be perfect with your wire throw. Otherwise, you're going to be hitting a screw, you're going to be hitting a plate, you're going to be very frustrated that you can't get your tightrope fixation in there. And so typically along the medial plate will be an oblong hole, an eccentric hole that the flexible device will fit into. So this is another time where I'll use the ACL guide. I'll go from one hole in the fibula to another hole that I want the fixation device to exit through the medial aspect of the medial plate, and I'll put the targeting device between those things. I'll throw my wire. Lo and behold, boom, comes right out that hole. You put your device in and you're done. So I found this to be a very helpful technique or trick to use in very unique circumstances. I think I've used an ACL guide like 3 times out of hundreds and hundreds. So by no means am I saying get out the ACL guide and use this all the time. I'm saying if you get stuck, think back to this and realize, hey, there's an easier way to do this.
Absolutely. Interesting case. I think it's a novel utilization of an instrument that's probably readily available for us. One thing I'd mention, and really more for the students, is when I see an X-ray like that, and you have an isolated medial mal fracture, make sure you ask for higher tib fib films too, to make sure you're not missing a Maisonneuve or a proximal fibular fracture. Because a lot of those PER type injuries can be proximal to a traditional ankle radiograph. That's kind of what I was thinking. But obviously a little bit different with a motor vehicle accident, but just something to think about.
No, you're 100% right. I did get proximal tib fib films. And when the tib fib films were negative for proximal fibula fracture, that's when I was like, I'm going to get a CT scan.
Yeah, no,
She's
absolutely.
19. This is a weird mechanism. I just want
Yeah.
to make sure I'm not missing something here. So, yeah, good
No, great
points on the
case.
proximal tib fib films. All right. Anything you'd like to add about ankle fractures and trauma?
Well, I think we definitely unpacked quite a bit, especially as it pertains to ankle fractures specifically. Yeah, I think going through an entire episode on pediatric fractures, I think would be fun. Kind of talking about some of those true ped fractures, some of those transitional fractures that we tend to see as well, like your Tolo and triplanes would be fun.
Yeah, for sure.
Um, but yeah, no, absolutely. I think there's a lot of good pearls, a lot of things that hopefully people can take home and put to use.
So I think we kind of envision this podcast as filling a void of, we learn a lot of things in school and you learn a lot of things in residency, but there's a certain population who may not see something very often or as often as they want to, and kind of providing a real world perspective of our, I don't know how many years you've been in practice, but I'm coming up on 9 years after
Yeah,
residency. You, after a certain amount of time, you've kind of seen a lot of things and can provide some amount of wisdom to the younger generation or even any generation, because you see some things enough and try to figure out some better ways to do something. So that's kind of the void that we anticipate filling here. So we got a
oh,
lot of
absolutely.
episodes planned and a lot of topics available.
Yeah, a good analogy that I think of is the things they don't necessarily tell you on the technique guides. You
Yeah.
know, you can read steps 1 through 10, but we know it's not necessarily gonna play out like that. So what are some of the things you might not be thinking of that you might wanna anticipate going into a case or going into any kind of patient encounter for that matter?
Yeah, exactly. So I go back to that sawbones analogy, right? Like very few patients' anatomy are like the sawbones. And so, if you
Yeah,
get good at doing something on sawbones, then that means pretty much nothing to me. So
especially a lot of us are
providing,
doing revision surgery or,
yeah.
second surgeries on patients, so that can really make things challenging when the anatomy is been skewed.
Yeah, they need to make some more realistic sawbones. They need to make like some sawbones with about 2 inches of fat between the incision and the bone. And they need to make some that are bigger and smaller. And the fibula has this weird
Yeah,
crest laterally, and I can't get the dang plate to sit on it because that stupid crest is there at the lateral fibula. Like, no one ever tells you that. Where's that in the
yeah.
book?
I don't mind the subcutaneous fat as much as some of the like, I remember I was dissecting through a lateral, proximal incision over the calcaneus, and there was at least 2 centimeters of scar tissue. I was just
Ugh,
digging through fibrous tissue. I could
ugh,
not even. Yeah, it
that's
was
horrible.
awful.
I hate
Yeah,
that.
yeah.
All right. Well, let us kind of wade through the garbage and tell you all the tips and tricks. So stick with us here on Pod Patrol as we continue to pump out some episodes and give you all the information that we've gathered over the years. So anything else you want to add, Leland?
No, just looking forward to next time. So hope you all have a good week ahead, and we'll see you next time.
All right. Signing off on Pod Patrol is Dr. Jeff Dikis,
And Dr. Leland Jaffe, take care.
Jeffy and Jaffe.